If your doctor recently told you your blood pressure looks perfect and you walked out of that office feeling relieved, I need you to stop and watch this video before you take your next pill tonight. Because I'm going to show you something that contradicts what most doctors in this country are still telling patients every single day. And by the end of this video, you are going to understand your blood pressure in a way your doctor's 15-minute appointment has never had time to explain. I'm Dr. Willaim, board-certified cardiologist, 32 years of clinical practice, more than 40,000 patients. And I can tell you with complete certainty, the single most dangerous word in blood pressure medicine for adults over 65 is the word perfect. Because for a significant number of older adults, the number their doctor is celebrating may be doing quiet damage that won't show up until 3 o'clock in the morning when they stand up to use the bathroom and the room goes dark. Before we go any further, drop a comment right now with just your age, nothing else, because what I'm about to tell you applies completely differently depending on whether you are 65, 75, or 85. And if you have ever felt dizzy or lightheaded when you stand up from a chair or get out of bed, add the word dizzy to your comment. You will understand exactly why in about 3 minutes. I want to tell you about Dorothy. Dorothy was 79 years old when her daughter brought her to my office. Sharp, funny, still drove herself to church every Sunday. She had been managing high blood pressure since 68. Her doctor started her on one medication, then a second, then a third. Each time the goal was the same number, 120 over 80. Each time her pressure came down, her chart got a note, BP well controlled. Dorothy trusted the process. She trusted the number. Then one morning, 4 months after her pressure finally reached 122 over 76, Dorothy stood up from her kitchen table after breakfast, reached for her coffee cup, and the floor came up to meet her. She fractured her left wrist, catching herself. The paramedics checked her pressure lying on the kitchen floor, 118 over 74, standing 86 over 58, a 32-point drop the moment she became vertical. Her brain had not been receiving adequate blood flow every time she stood up for months. The dizziness she mentioned to her doctor twice was recorded as age-related orthostatic changes. Patient advised to rise slowly. No medication adjustment, no further testing, just rise slowly. Dorothy's wrist healed, but Dorothy did not return to who she was. She became afraid of her own kitchen. She stopped driving. Her world shrank to the distance between her bedroom and her couch. 11 months later, she developed pneumonia from the reduced mobility. She was hospitalized for 9 days. She survived, but she never drove herself to church again. Dorothy's daughter asked me afterward, how can a perfect blood pressure number do this to someone? That question is the reason I'm making this video. Comment dizzy right now if you have experienced lightheadedness when you stand up, because Dorothy's story may be your story and you may not know it yet. What you have been told is incomplete. For decades, the message has been simple. Lower blood pressure equals better outcomes. 120 over 80 is the goal. Lower is safer. And for adults in their 40s and 50s, that is largely true. I have prescribed it myself for 32 years. But something fundamental changes in the cardiovascular system after 70. And the guidelines most doctors are still using were built on studies that were never designed to answer the question of what is safe for your body right now. I am not going to give you the target number yet, because if I give it to you now, some of you will write it down and close this video. And that number, without the context that comes before it, could be more dangerous than no number at all. You need to understand why your body, at 75, is physiologically different from a 55-year-old's before that number can protect you rather than mislead you. What the research actually says. In 2015, a landmark trial called the SPRINT trial enrolled 9,361 adults over 50, average age 68. An intensive group aimed for below 120 systolic, a standard group aimed for below 140. The headlines were enormous. Fewer heart attacks, fewer strokes, fewer cardiovascular deaths. Less than 120 became the rallying call. Prescriptions were written, doses were increased. Dorothy's chart got a gold star. But here is what the headlines never told you, and what most doctors have never had 15 minutes in an appointment to explain. The SPRINT trial excluded patients with diabetes. It excluded anyone with a prior stroke, anyone with dementia, anyone with advanced kidney disease, anyone with severe frailty. In other words, the landmark study that established the target your doctor is chasing was testing less than 120 only in the strongest, most medically uncomplicated older adults in the pool, not the average 78-year-old with 3 chronic conditions and 4 medications, not Dorothy, not in many cases you. And the same SPRINT trial documented that the intensive group had significantly higher rates of dizziness, fainting, kidney complications, and falls requiring hospitalization. The cardiovascular protection was real, but so were the consequences. A separate trial, the STEP trial, China 2021, 8,511 adults aged 60 to 80, produced nearly identical findings. Lower target group, better cardiovascular outcomes, and more falls, more dizziness, more kidney strain. 32 years of practice has taught me this. Those trials answered an important question, but they answered it for a population that does not represent the majority of older adults sitting across from me every week. And the guidelines built from them have been applied broadly to patients who are specifically excluded from the data that created them. That gap between the research population and the actual patient in the exam room, that is where Dorothy fell, literally. Why your body after 70 is not your body at 50. 3 things change in your cardiovascular system over time that make this matter so much. First, arterial stiffness. Picture the garden hose coiled in your garage for 20 years versus a brand new one. The old hose is rigid. It does not flex. Your arteries undergo a similar process over decades. When your heart pumps blood into stiff arteries, they cannot absorb the pressure wave the way they did at 45. Your body needs a slightly higher baseline pressure to ensure blood reaches your brain reliably, especially when you are standing upright against gravity. Second, baroreceptor sensitivity. Your blood vessels contain tiny pressure sensors called baroreceptors. In a 30-year-old, they detect a drop the instant you stand and signal your heart within milliseconds. In a 75-year-old, those sensors have slowed. If your baseline is already 120 and your baroreceptors are sluggish, the drop when you stand reaches your brain before your body has time to correct it. That is the room spinning. That is Dorothy's kitchen floor. Third, medication metabolism. Your kidneys and liver at 75 do not clear medications the same way they did at 50. A dose calibrated perfectly 5 years ago may now be hitting harder, staying longer, pushing your pressure lower than the office reading suggests. A sitting pressure of 122/76 looks ideal on a chart. What it cannot show is what happens to that number the moment you become vertical. Here's what I want you to do tonight. 3 minutes. One thing. A home blood pressure monitor available at any pharmacy for about $30. Lie flat for 5 full minutes. Rest completely. Check your blood pressure lying down. Write both numbers down. Now stand immediately and check again right away. Do not wait. Write those numbers down. If you're systolic, the top number dropped more than 20 points, or you're diastolic, the bottom number dropped more than 10 points, you have orthostatic hypotension. That is what was happening to Dorothy every morning for months before she fell. Write those numbers down. Bring them to your next appointment. Do not accept that's probably just age. Orthostatic hypotension is measurable, addressable, and often medication related. Your physician can act on it if they have the data. This is the test most doctors are not performing at routine visits. Now you can perform it yourself. Comment the word test right now if you are going to do this tonight. Before I give you the framework, I need to ask you something directly. This channel exists because I believe older adults deserve the same clinical information I give patients sitting in my office. Not simplified, not watered down. The real framework in plain language from a physician who has used it for 32 years. We are working toward 100,000 subscribers because every subscriber tells YouTube this information belongs in front of more people. More people means more families who have this conversation before someone falls. If this video has given you something your doctor's appointment never has, please subscribe and like this video. It puts this information in front of the next person who needs it. That person may be someone you love. Now, here's a framework I use for my own patients. Find yourself in it. Know your real number, not the number on your chart, the number that reflects your age, your physiology, your medication load, your fall risk, and your quality of life. If you are 60 to 74, active and independent, no significant chronic conditions, not on multiple medications, a systolic target of 125 to 135 is reasonable and well supported for your profile. If you are 60 to 74 with diabetes, prior stroke, multiple medications, or any pattern of dizziness when you stand, do not chase 120. A target of 135 to 145 provides meaningful cardiovascular protection without the fall risk your profile carries. More medications are not always more protection. Sometimes they are more dangerous. If you are 75 to 84 and relatively healthy, the evidence now supports 135 to 145 as the range associated with best overall outcomes, not 120. The research consistently shows lowest mortality in the moderate range, not the aggressive target built for the 55-year-olds in the original studies. If you are 85 or older, or frail at any age, preventing falls is a higher clinical priority than an aggressive target. 140 to 150 systolic may be the safest zone for your physiology. I know that looks high compared to every pamphlet in every waiting room, but we are not treating a pamphlet, we are treating you. And one number almost nobody addresses, your diastolic, the bottom number. For older adults, I want that above 65, ideally 70 to 85. When diastolic drops below 60, blood flow to the heart during the relaxation phase becomes compromised. If yours is consistently below 60, even if your systolic looks fine, that conversation needs to happen at your next appointment. Bernard is 72. He golfs twice a week. No diabetes, no prior cardiac events, good kidney function. Blood pressure running 142 over 84, and he feels completely well. His doctor wants to add a second medication to reach 120. My recommendation? Leave it. The risk of pushing Bernard into orthostatic territory outweighs the marginal benefit at his profile. Bernard is still golfing. Gloria is also 72, same blood pressure reading, but Gloria has type 2 diabetes, one prior cardiac event, and reduced kidney function. For Gloria, 142 over 84 carries real risk, but 120 is not her target either. Her kidney function and diabetes create a perfusion profile. The aggressive target would destabilize. Gloria's target is 130 to 135, reached gradually with orthostatic checks at every adjustment. Same number walking in, different targets walking out. Because we are treating Gloria, not the number on her chart. That is what know your real number means in clinical practice. What to do with your doctor? If your doctor has a target for you, I am not asking you to discard it. I am asking you to have a more specific conversation. Bring your home blood pressure log morning and evening for 2 weeks. Bring your orthostatic test results from tonight. Bring your symptom inventory, dizziness when you stand, unexplained fatigue, brain fog in the mornings. These are not simply the facts of getting older. In the presence of blood pressure medication, they may be your body telling you the number on your chart is not the number your physiology needs. Ask directly. Given my age, my conditions, and my medications, is 120/80 actually the right target for my body? A physician current with the research will engage that question, and the data you bring makes the conversation possible. Dorothy's daughter once asked me why this information is not standard. Why is every doctor not having this conversation with every patient over 70? The honest answer? Medical guidelines are slow. The research is years ahead of clinical practice, and it should be changing. Doctors in 15-minute appointments are working from frameworks that have not yet caught up to what the data now shows. That gap is exactly what this channel exists to close. If this video gave you something your last appointment did not, please subscribe to this channel right now. We are building toward 100,000 subscribers because that number tells the algorithm this information should reach every older adult searching for it tonight. Please like this video, share it with someone over 65 on blood pressure medication who has never had this conversation. Your share may keep someone else's mother out of an emergency room. That is not an exaggeration. That is Dorothy's story, and it is preventable. Dorothy still calls my office twice a year. After her wrist healed, we reduced 2 of her 3 blood pressure medications. Her pressure settled at 138/78. Her orthostatic drop went from 32 points to 11. 6 months later, she told me she had started driving herself to church again. That is what the right number looks like. Not the number on a guideline, the number that keeps Dorothy in her car on Sunday morning. You now understand something the standard 15-minute appointment has not made time to tell you. You know blood pressure targets are not universal. You know the landmark study behind the 120 excluded patients like you. You know the 3 physiological reasons your body requires a different framework. You know how to perform the orthostatic test tonight. And you know the tiered framework 32 years of clinical cardiology has taught me to use for real patients, not idealized research trial participants. You are not a number on a chart. You are a person with a specific body, a specific history, and a specific set of risks that deserve a specific answer. Know your real number and make sure the person prescribing it knows you, not just your chart. I will see you in the next video.